Good evening. I'm Dr. Renee Matthews, your host from blackdoctor.org. Thank you for joining us for this community conversation in partnership with Cedars-Sinai for an important discussion about perinatal mood and anxiety disorders, or PMADs. According to the American Counseling Association, Black women are at higher risk for prenatal and postnatal mood and anxiety disorders, such as depression, anxiety, and post traumatic stress disorder. Our experts will discuss why this is the case, along with the importance of diagnosis, support, and treatment. You'll also learn about an important study on Black maternal mental health and how you can get involved. Tonight, you'll also hear how one patient turned her experience into a comedy routine and became a force for legislative change, and how another woman created an app to improve Black maternal mental health. But before we jump into this, let's talk about the term PMAD, or perinatal mood and anxiety disorder. Perinatal is the term used to refer to the period before birth, where you may know about postpartum depression. A perinatal mood and anxiety disorder can develop at any point during pregnancy and up to 1 year after having a baby. So tonight, we will be using the terms birthing people and mothers to be inclusive. So let's meet our panelists. And by the way, we are starting Black Maternal Health Week, so that's where this conversation is great to have right now. So our first panelist is Dr. Kimberly Gregory. She's with Helping Hand of Los Angeles, Miriam Jacobs Chair of Maternal Fetal Medicine at Cedars-Sinai, where she's also the Vice Chair of Women's Healthcare Quality and Performance Improvement in the Department of Obstetrics and Gynecology. She also chairs the State of California Pregnancy Associated Mortality Review Committee. And then we have Dr. Einav Akort, and she is a clinical psychologist and research scientist. She is the director of the Reproductive Psychology Program at Cedars-Sinai. And then we have Dr. Simi Bambouje. She is a reproductive psychiatrist at Cedars-Sinai. And so together, Dr. Akort and Dr. Bambouje and Dr. Gregory and community partners, Candlelit Care and Maternal Mental Health, they now launched the Resources, Inspiration, Support, and Empowerment, also known as RISE, study to better understand the maternal mental health of Black birthing people. And I told you we'll give you more information about that so that you might possibly be able to get involved. And joining us from Candlelit Care, Lauren Elliott is a maternal mental health advocate. She is the founder and CEO of Candlelit Care, an online therapy clinic created to offer women and birthing parents at risk of perinatal mood and anxiety disorders with health coaches and licensed therapists with culturally affirming mental health coaching, with an emphasis on wellness that centers Black joy. And finally, we have comic Angelina Spicer. She gave birth to a child at Cedars-Sinai and turned her personal experience with PMAD into a stand-up comedy act and platform for advocacy. So we've got a lot to talk about today. So let's get started. But before we begin, if you're watching us tonight on any of the platforms, please share. Sharing is caring. And if you have questions for any of our panelists, do me a favor and please type them in the chat. And we will have somebody make sure that any of the questions, we will try and get those addressed for you. So here we go. So let's ask the doctors first about PMADs. What are they, and what are the symptoms and risk factors during pregnancy or after birth?
Well, I'm happy to take this one. I just want to thank you so much for including me in the program. I so appreciate it. Yes, I also appreciate you sharing that we now use the term perinatal mood and anxiety disorders. I know when I entered this field 20 years ago, all we ever heard about was postpartum depression.
Exactly.
And a lot of people only talked about postpartum. And so we knew as women and as birth givers what that meant. But it is a little confusing because postpartum is just a time, and postpartum depression is just one of several of the disorders or experiences that a birth giver could have. So we know anxiety is more common than depression during this time of life. And we know that these symptoms can begin in pregnancy. So it's not just after you have the baby. So that's why we include clinical depression, generalized anxiety, panic disorder, PTSD, all of the different conditions that you might hear about, they can come up for the very first time during pregnancy and the postpartum period. And the term perinatal mood and anxiety disorders include all of
Does anyone else want to add anything? Okay, so Dr. Gregory, we know about the Black maternal health crises in this country, with Black women experiencing higher rates of adverse pregnancy outcomes, including death, compared to women of other racial and ethnic groups. Tonight, we are discussing how Black women are also at a higher risk for PMADs. Why is this? Is it interrelated? How can doctors work to reverse these devastating trends?
So it's absolutely interrelated. The causes of PMAD are multifactorial, but in addition to the inherent biologic risk for specific individuals, they can be exacerbated by life events and chronic stressors and the birth itself. And the chronic stresses and life events happen to Black people daily. So, to the extent that it goes unrecognized or contributes to unhealthy lifestyles and behaviors, such as substance abuse or an inability to comply with medical or behavioral treatment recommendations, it has been associated with increased maternal morbidity and mortality. And in fact, suicide and substance use disorders are the leading causes of maternal mortality in many states. And you asked what doctors can do about it, and not doctors, but the health system in general. We can work to reverse the trend by universal screening for PMAD, supporting treatment, initiating treatment, and being aware of community offerings for wraparound services. So I'm a high-risk OB, and I can say that if you come to me on medication, I'm very supportive and reassuring, but I don't generally tend to start medication myself. And as Dr. Bombazet can help us with, there's no reason why we as primary care physicians can't start initiating treatment.
Thank you. So before we dive a little deeper into PMADs, let's turn to Angelina Spicer. Can you share more about your story?
Absolutely, I'd be happy to. Dr. Renee, thank you so much, and thank you to the distinguished panelists. I got to tell you, as a stand-up comedian, I'm always floored by how many doctors I'm in the room with now. And I got to tell you, it just fills my heart so much to be able to add to this conversation, because when I was going through postpartum depression and anxiety at the same time, I really just I didn't know of anyone else that was discussing these things openly. So to be invited into these spaces and to be invited, especially by blackdoctors.org and Cedars-Sinai, where I deliver, it is really a distinguished honor to be here and to be included. I will say I always start off by telling people that my child was planned. Okay. I am married, was married. We had stability, we had education. My husband is an attorney. You know, I'm an educated person. I went to college. I come from an educated family. We are stable. We're homeowners. I did not have any adverse risk factors. Healthy within the gestational period, all the things. We planned it properly. And at 30 weeks postpartum, I can say this because I'm in a room full of doctors and not a bunch of drunk folks at a comedy club. But at 30 weeks, I was labeled high risk. And at that time, I did not know what that meant. I didn't feel like my husband and I got a very clear indication that we were quote unquote high risk. It was actually after delivery and almost a year postpartum that I realized that because my daughter was growth restricted, that meant that I was high risk. So I always thought that high risk was if you were pregnant after 35. Mm-hmm. But growth restricted was the reason why I was labeled high risk. And I was having to, do follow-up appointments and consistently go to the doctor, which I did for checkups and things like that. But I did not know that at that time I was developing anxiety. Right? Fast forward to 8 weeks later, thankfully I was able to remain pregnant, although I was high risk, and I delivered a very healthy baby, thank God. But I was traumatized by the process of giving birth. I attended all the prenatal classes, read all the books, did all the things, but there's nothing like pushing and praying and hoping for a healthy baby, a healthy experience. And I was just traumatized. I was scared. And the moments after I gave birth and they laid my daughter on me, I looked like I had seen a ghost. I looked like I had seen a ghost and that I was about to get jumped by the KKK. Okay. So it was not a good look on my face. Okay. And when I got home, it got worse. When I got home, my husband and I, we returned home with our new baby. We had grandma's help there, but I was just scared. I was scared. I was ripped to shreds. I felt like my body was not my own. My body was hurting and I was in pain. In pain, I mean, from the stitches, let's be clear. I wasn't hemorrhaging. There was no crisis. This was just normal wear and tear on the body after you give birth. I just felt like nobody told me that, honey, you won't be able to walk up some stairs. Okay. You will see stairs and you will cry. You will decide, listen, I'm just not going to walk up these stairs today. So the situation just felt like it was getting worse. I wasn't sleeping. My husband wasn't sleeping. The intrusive thoughts kicked in. I did not know that intrusive thoughts were very common and common within 70% of women who give birth. Nobody raised that red flag for me. So I was scared of my own thoughts. My vagina was hurting. My legs and my feet were swollen. I was spraying breast milk all over the walls and just not sleeping. So it was a mess. It was a hot mess. And luckily I had a therapist, thank God for Dr. Olson, who also treated me at Cedars. And Dr. Olson was incredible. She guided me through my emotions and she ultimately referred me to a psychiatric facility for treatment to postpartum depression when I was 8 months postpartum. Now, this came as a real shock to me because I did not know that that was even an option. Okay. I just wish someone had said, hey, Angelina, if you want to check out, honey, you can check into the psych ward and insurance will cover it. So I went willingly to the psych ward because I wanted to feel better. And a doctor that I trusted told me that I should go. So I went. And it was a glorious 10 days at the psych ward. Okay. Everybody checked on me every 15 minutes. They prepared my meals. I was able to take a shower for as long as I wanted. It was a beautiful experience compared to being at home with a newborn. Highly recommended. And then that's when my advocacy started. My advocacy started when I left the psych ward and I returned home, and my family finally understood that I needed more support. And this is another reason why I'm so happy to contribute to these conversations, because my family did not understand the severity of what I was expressing to them.
Mm-hmm. Mm-hmm.
In fact, many of them told me to pray it away. They told me to pray it away and that we don't claim these thoughts because once we claim these thoughts, we own these thoughts. But I was like, honey, these thoughts ain't going away. I'm going to need somebody to help. Phone 911, call the psych ward, call my therapist, call somebody. So that's when my advocacy started. And I have really been using not only my platform, I've been just using the power of comedy to talk about it, right? So much of what I experienced what felt like a lie, felt like everyone had lied to me, had duped me. I did not feel prepared from anyone. I didn't feel prepared from my doctor. I didn't feel prepared from the many of the nurses. I didn't feel prepared from my own family, from the women in my life who had given birth, from my cousins, from my own mother. I just felt like everyone lied to me. So I am using whatever little bit of jokes I have to make sure that mamas know that, honey, your vagina is going to be ripped open and you can go to the psych ward if you need to. Insurance will cover it.
So, Dr. Bambashay, could you talk about the signs and symptoms of depression so that our audience, if they're pregnant women or pregnant birthing people, or if they are the other side and they're watching a family member spiraling or something, then they would recognize what's going on?
Yeah, I mean, Angelina, first of all, your description, it's so funny, but also so real. I'm so sorry to go through it, but it just really highlights what I have seen before in terms of what we're talking about when we're talking about depression, anxiety, especially I think the one thing that people really have a hard time with is that anxiety, which can show up as nervous energy, like they're cleaning all the time and they're constantly watching the baby. So people might see them and think, oh, they're just like great super moms, but it's actually maybe OCD that if they think that if they stop cleaning, the baby's going to die, or if they like pick up a knife, they're going to accidentally kill their baby. So those kinds of thoughts, those are the intrusive thoughts you were talking about, where they come up and we don't want to share them with anybody because it sounds crazy, right? So that anxiety is there. And then with depression too, it's a lot of times it's feeling more tired than what seems like other people who just had a baby feel. Like you just can't get out of bed. You can't take care of the baby. You can't go outside. I have so many patients who are like, I haven't left the house in 2 weeks because I just can't. Either they're afraid of something happening or they just don't have the energy. So it's really this, or even worse, they start to think my baby would be better off without me. I'm not a good enough mother. I'm not a good enough parent. So all of these thoughts that come up are things that we can recognize in our family or our friends if we're seeing that happen to them, and just trying to be more supportive. I think also one of the things you talked about, Angelina, was the traumatic experience you had during pregnancy and in the postpartum. And so we also include PTSD and perinatal mood and anxiety disorders. And it's, I think, a highly underdiagnosed complication of pregnancy and delivery, because even if your doctor said you're fine, you just have one stitch, everything's great, if it was traumatic for you, you can still have PTSD. And so those are things too. We have nightmares that people have, again, that anxiousness, not feeling like they can leave the house. So those are some things to look out for. If you were previously somebody who loved to go out and see friends, and now you don't want to see anybody, then that's definitely a bad thing.
Yeah, that is very helpful. So, Dr. Gregory, how do OBGYNs help identify and treat PMADs? And what are some questions new mothers and parents should ask if they're experiencing this mental health issues?
Mute first, right? Before I talk.
It's okay.
I think most health systems routinely screen for PMAD, and usually at several times throughout pregnancy, using either the Edinburgh or the PHQ screening tools. But the extent to which individual doctors are doing it is unknown. And so it's important for patients and families to bring it up. And, you may be fine in the first trimester, but not in the second or third trimester. Or as Angelina pointed out, once we have sometimes 3 minutes or 5 minutes to tell somebody that they've gone from a normal pregnancy to a high-risk pregnancy. And if you're their primary OB, you have a relationship with them. But if you're a specialist, you're trying to navigate all of that in a 15-minute visit. And sometimes I can just feel the anxiety, like, ooh, I just made something bad happen, And fortunately, at our hospital, we have the opportunity to literally say, do you need to talk to somebody? And then, call 911 and have a social worker come and connect and say, okay, let me get you some wraparound services that would be helpful. And I'm going to defer to my colleagues on how to get family to reach
That's
out.
what I was going to say. How can we have family members advocate for our pregnant people if they suspect something's going on?
I was just going to add one quick thing, but I was hoping Lauren might be able to add to that quite specific question about families. I just really want to highlight and sort of piggyback on what everyone has said and mention that this is incredibly common. So 1 out of 5, we hadn't mentioned any prevalence rates. So I just wanted to throw this out there that 1 out of 5 new mothers will meet criteria for the type of depression and anxiety that Doctors Gregory and Bambage have described that interferes with their functioning. So we're not talking about a little bit of worrying, all that's normal. Is my baby gonna be healthy? Am I gonna be okay? But what Angelina described is that next level where she's not able to sleep, she's not able to interact, she can't do what she needs to do in a regular day. I think family members can see that. I think they can see when someone isn't their usual self. So Lauren, what would you add to that as far as having family members?
Thanks, Dr. Court. It's totally, that's correct. That it's just generally, if a mom is just choosing, sometimes these are just emotions that we're just kind of wrestling with ourselves. We may not be able to verbalize these things. So we sort of rely on people just kind of seeing the signs. Family members are crucial, especially for, culturally speaking, with Black women, less likely to be sort of asked for help and ask to be supported in these sort of nuanced ways. Culturally speaking, different things happen around the birthing experiences where family members may bring you food. That doesn't always happen, though. So I think there's this disappointment among a lot of moms, especially Black mothers, where they're just not being kind of surrounded or by like this abundant, support and love. And that's down to Angelina's point, where it's like, oh, that's I thought that was going to happen. So I think as much as family members can show up, just look out for the signs, especially around pregnancy and especially postpartum after the birth has already happened, where, hey, I noticed you don't do this anymore. Or, and just delivery is everything. Delivery is key, making sure that the person still feels like they can control things, but just showing up, I think, is the best way that family members can support their loved ones.
I would say two things: that family members, there's what I call 1,000 acts of kindness. Like, in fact, I was coming through Atlanta. I'm in Atlanta at a meeting, and there's a woman, and she had her baby. She had two babies. She was carrying one, and the other one was in a little thing, and she had like two suitcases wrapped around her neck. And I looked at this lady, and I'm like, "Can I help you? Like, you look like you need help." And this woman like just cried, like, "Oh my God, thank you so much." I'm like, "Look, I've been there. I know." So I think that that's one thing that family can do. They can just realize that we need help. But the second thing is they can say, it's okay to get a therapist. It's okay to go on medicine. And that's something that, as a Black doctor and as a Black woman, we always aren't comfortable with seeing a therapist or taking medicine. Like, oh, that might harm the baby. Well, the studies are really clear that the harms of depression and anxiety, on a risk, not for everybody, but on a patient by patient basis, the benefits exceed the risk. And I think one of the other questions is going to be, well, will it harm the baby? And the studies, as best that we know, is that no. Now, yes, some babies will have withdrawal symptoms, so your pediatrician should know. But again, the benefits outweigh the risk, and the risk of actual structural defects are minuscule for almost all drugs to date. And there is one, and that's the lithium, which we do if you're on it when you get pregnant. There's a little extra ultrasounds that we do to make sure that the baby's okay.
So I just want the audience to understand. So there are people that they knew that they were having, mental health issues before they got pregnant. So when they are in pregnancy, you don't have to just all of a sudden cold turkey stop your medication. That is a bad idea.
Please
Never
don't
advise to do that. Please don't do that. Talk to your doctor and make certain that they are aware, because obviously your OBGYN may not necessarily know what the psychiatrist prescribed for you. So make sure that they know that you are taking something, so then they can make certain that it is safe and they can put you at ease.
Mm-hmm.
And then I think the other issue we have in our community too is that, they push breastfeeding. And then of course, if you say, okay, well now I have to take something because I'm having, these thoughts, this depression or whatever. And then of course, now the mother's like, well, can I breastfeed or whatever? So then I think that's where something else,
Mm-hmm.
Yeah, I would like to add, if possible, the point about families, how families can help. My husband went behind my back and went to my therapist and made a call and was like, she's not well. Okay. Then he called my mom and was like, mother-in-law, she's not well. And I did not know that he did that. It was an act of kindness, like Dr. Gregory mentioned, and I am forever grateful to him for doing that. I'd also like to mention that that it's important to get ahead of these conversations, right?
Mm-hmm.
And earlier that Black women in particular are at higher risk for developing perinatal mood and anxiety disorders. And I think it's important that we get in front of the conversation before the baby gets here, right?
So get plans in place.
Agree.
So
Yeah,
if you where there is no family,
maybe
then
there is no plan. Maybe let's say we don't have an opportunity to plan, but we need to have an opportunity to be educated that this is a thing. This is a real thing that 1 in 5 women experience. But if we just had the name, and we had an example of what it looks like, what it might feel like, that mom will feel so much more comfortable expressing how she's feeling to her doctor. Without knowing that 70% of birthing people experience intrusive thoughts, how are you going to call your doctor and say, oh my gosh, every time I walk down the stairs with my infant, I feel like I'm going to slip and fall and the baby's going to fly out of my hands and we're both going to die, right? These are recurring feelings that a lot of moms have, myself included. I had, at 2 or 3 o'clock in the morning every night when I'm breastfeeding. If we get ahead of these conversations and moms or birthing people have just the information that this is what this is a real thing, and that we can work through it. We can work through it, and there are systems in place to treat you should you feel like we need to take it a step further.
Definitely. So Dr. Acord and Dr. Bambage, when it comes to PMDs, what are the risk factors for Black birthing mothers?
So I'll start with this, and I know Dr. Acord will add if I forget something, which I might, but the risk factors are, unfortunately, there's so many risk factors. There is a history of depression and anxiety before, which is probably one of the top risk factors. There's people who are really young when they get pregnant, and they're like early teenagers, people who are older, so older maternal age people have higher risk. People who have financial stress, relationship stress, people who have complications during pregnancy. So like Angelina said, she was totally fine, and then all of a sudden she has complications. So that increases the risk. Traumatic pregnancy, low family support. So all of these, and then of course, as Dr. Gregory mentioned earlier, just racism in general, just the medical racism that Black women and Black birthing people experience, unfortunately, every day as we go about our lives, as we go to the doctors, people not listening to us, people dismissing our concerns. So being not heard for so long has unfortunately an effect on developing any one of these conditions. And I think too, to talking about the risk factors and tying it back a little bit to what we were talking about before with getting family involvement beforehand, one of the things that I've been trying to do, of course, I'm a psychiatrist, so I'm seeing people who already have been diagnosed, they're already probably taking medication. Maybe they haven't had a child before, but I'm already seeing them. Maybe they had postpartum depression or anxiety, and that's why I'm seeing them. But I really try to get ahead of it. I try to have some family member or somebody in a visit with me before the baby comes. Do we have questions? What do you want to look out for in your partner? I specifically go through it. I try to have a family member with me postpartum. I'm always asking, what is your partner saying? You say you're doing good. Would your husband agree with that? And sometimes you have the husbands in the background because I'm on Zoom and they're like, no, she's not okay. So I'm like, okay, well, let's bring him over. So I think those are ways to really just try to make it normal, have it be a family conversation. I'm not going behind any of my patients' back, but I'm letting them know if we can talk about this early, everyone around us knows what to look for, then everyone's going to be in a better position.
Everything you said was perfect. The only thing I would add is that there's biopsychosocial risks, and don't discount any one of those. And what we're talking about today, specifically Black maternal mental health. So if the risks are 1 in 5 pregnant people, for Black women in particular, it's 1 in 3. So that's highlighting what you're talking about, Dr. B, which is that daily microaggressions, specifically medical racism, these are the kinds of stressors that add to weathering and cause the higher risk, one of many risk factors. And so it's important, as Angelina said too, educating in advance, not just the woman, but her family, which is, I think, what Lauren's whole platform is about with Candlelit Care. So I know we're going to get to her awesome program.
So Dr. Gregory and Dr. Bambage, can depression and anxiety during pregnancy affect the baby? And is mental health so we talked about that medication, and Dr. Bamajay, if you want to expand upon that, you can. But is the depression and anxiety, would that help the baby? I think I know the answer, but
So that's pretty complicated. To the extent that depression and anxiety lead to stress, and we think that the ultimate pathway is inflammatory, and that the molecular pathway is DNA methylation, right? And so that's what they're calling the allostatic load, or the weathering, or the biochemical results that we can measure from stress, inflammation, and racism. That is inherited. I mean, that does get passed through the DNA. We think that some of that process is associated with preterm delivery. It may be associated or exacerbate hypertension. We don't think it's, well, anyway, there's a lot of pathways going on. So it's a long answer to say probably, but we're still working out the mechanisms for it.
okay.
Which
Dr.
is why
Bam-
treatment is key.
Yeah, definitely. And I think, and there's also evidence, so maybe not in utero or in terms of birth complications, that we're still, again, as Dr. Gregory said, working out the mechanisms and what we see, but we know that there is higher risk of depression and anxiety in the children of mothers who are not treated for depression and anxiety during pregnancy and the postpartum period. Because if you think about how a depressed mother or an anxious birthing person is, if they're maybe missing doctor's appointments because they're too depressed, or they're drinking because they're feeling really anxious. And so these are things that definitely can have a clear outcome. But also, if you think about how hard it is to interact with your child, if you're not able to sit and play with your child because you're too depressed, or if you're so anxious that you won't let your child do anything, that is going to affect their ability to grow and develop into healthy humans.
Yeah. So Dr. Acor, why was the reproductive psychology program at Cedars-Sinai created, and how common is it for there to be a program like this in any other hospitals in the country?
Yeah, thanks for asking, Dr. Renee. So the reproductive psychology program was launched in 2019. At that time, so we're relatively new.
Mm-hmm.
At that time, I could count on my hands how many programs like that existed across the country. I'm so proud and happy to share that there are many, many more. Only in just the past 5 years since I've been doing this at Cedars-Sinai. And the need is great. So we're talking about this 1 in 5, and we're talking about people who really need support outside of, so when we have so mild symptoms, you could go to church. I'm not saying pray it away, Angelina, but you could go, and talk to a close friend or your pastor. You could talk to mom. You could go to a mommy and me and feel better. But it's when we get to the moderate or severe depression and anxiety that we do need, as Dr. Gregory and Dr. Bamajay talked about, other interventions like psychotherapy and medication management, which is what we do in the reproductive psychology program. So the idea is, as Dr. Gregory already mentioned, hospitals screen routinely, ask the question, but that alone isn't enough. We can't just ask the questions. We have to educate, like Angelina was talking about, right? And we have to refer to appropriate, vetted maternal mental health care, ideally culturally relevant maternal mental health care. So the idea here is that a program like this ideally is embedded in an OB-GYN department. And so the physicians and all of the multidisciplinary team is working together. And the topic is brought up as family wellness. So we're not saying, here's this depression screen, fill this out. Like, oh my goodness, in front of your mother-in-law, right? That is just not something anybody wants to do. So,
and most moms will lie anyway, but keep going. Sorry, Dr.
I appreciate you saying that, because that's the reality, right? So let's be real. Let's understand that if we're going to spotlight you and we're going to say it's about depression and we're going to feel like, oh my gosh, any single person is going to think, why are they asking me these questions? Are they calling Child Protective Services on me? I'm just 0, because I don't understand it. I mean, there's research to support that women of color and this is unfortunate, but that social services are called and child protective services are called on women of color more than white women.
Yeah.
And they're reporting the same kinds of things, depression, anxiety. They're not reporting thoughts of harm or even suicidal ideation or homicidal ideation. They're just saying, I feel depressed. So that's not okay. So at Cedars, we created a program where we educate our nursing staff to bring up the topic of family wellness and to hand them an iPad where the Edinburgh screening is there. And, they're allowed to do this thing, and the nurse stays in the room and says, if you have any questions, you let me know. I'm right here. And if they screen high, they try to have a conversation and offer a social worker. So it's not like you're in trouble. Again, it goes back to understanding the risks. And, I mentioned before about biopsychosocial risks. I think one thing is really nice and easy for the doctors and nurses to do. You can see in a person's chart if there is a personal history of any kind of mental illness. And as Dr. Bambagé mentioned, that is the number one risk factor, and that's the bio. When I talk about biopsychosocial, that's the bio, right? The psychological piece is that becoming a mother, becoming a parent, especially for the first time, I'm just giving an example of a psychological risk factor, is one of the biggest life experiences you will ever have. And so like adolescence, which can be really okay and not too damaging, it can also be really challenging and you need help. Matrescence, similarly, is a developmental stage that all women go through, and we can have role overload, right? There is no such thing as super mom. I actually hate that term because it makes people feel pressure as if I can be the best mom, the best wife, the best worker, the best this. So again, and then the social pieces, we're talking about medical discrimination, right? So to give you some other examples of what I mean, we can be aware of that. The nursing staff can be aware of that. The social workers can be aware of that before we even walk into the room, and before the reproductive psychology program even meets you, we can begin that conversation.
So Lauren, please tell us, how did you created Candlelit Care. And so can you talk more about why you created it and why it's culturally affirming care like this, why this is important? But I think we've covered why it's very important.
Yes, very important. No, and it's just amazing to be among you all and talk. Yeah, I think like Candlelit Care, it definitely was born out of frustration. I dealt with depression and anxiety with my oldest. I have 2 boys, and I didn't have anywhere to go. Didn't really know what I was experiencing, and that I really focused Candlelit Care specifically to be that support system, that sort of built-in support system that can educate women and birthing people on what they're experiencing, really not to replace therapy or any like sort of other therapeutic practices, but just really to augment and focus on parents just knowing what they're experiencing so they can feel more empowered to verbalize this to their doctors or their midwives, and also know how to navigate these through an entire pregnancy, an entire postpartum period. We've had parents who have experienced perinatal loss and then had become pregnant again. And these are just experiences and journeys that cannot happen in silos. So Candlelit Care has really been developed to basically be able to coach parents through these experiences, screen them. So the coaches do have the ability to screen, but only for the betterment of the parent knowing, hey, this is what I'm experiencing. And just being able to verbalize these things when we don't often have spaces and feel comfortable to share, as we've all been discussing tonight. Like it's just so rare that happens. So how can we create more of these opportunities? And Candlelit Care really is a conduit to Dr. Bambagé, Dr. Gregory, Dr. Akar.
Right. I was just going to say, this kind of helps people get the words together so they know what to say to the doctor, and they know you actually should go tell your doctor. You now know exactly what's going on, kind of, so that they can help you.
Yeah, how can we help women and birthing people feel more equipped with the language? Because Angelina's story fully resonates with me. Like, we don't have a language to even express to our family members what we're experiencing, and when we do share that, then it's either dismissed, and so we're just being dismissed by everyone. So it can feel very like a mountain. And
because your mother didn't experience that, so that's why she's like, "You're fine."
My mom literally said that I didn't have time to be depressed. That was my oldest, yes. And that woman has never seen a therapist. Sorry, Mom. But yeah, that's the thing. We have to break these cycles and be able to talk about these topics, not treat them as taboo, not further stigmatize them. So kind of care, you can think of it as another intervention and solution to just create that change.
And it's for all members and all parties involved, not just the moms and birthing people, right? Okay. Because I really, when Angelina said that, I was shocked because most men, they just blanket, just don't pay attention. You know what I mean? So for the fact that your husband caught on to that, because honestly, I would have thought your mother would have said, you need to call her doctor because something's not right. But for your husband to have done it the other way, I just find that to probably be exactly applaud. And I think that's probably very rare. So, yeah. And I think that men would definitely appreciate, especially like I know my cousins are the bomb fathers, and they, as a matter of fact, I told them, I was like, my clients wrote this great book about pregnancy and stuff. I'm sending it to you. They were excited because they're those kind of men, but not everyone's like that. And so I think that they would appreciate a candlelit care because they would get the information they need to help they love their wives and they want to make sure that everything's okay. So
I also would like to add that I was surprised at how many men were aware, interested, wanting to learn about what we experienced before, during, and after pregnancy. I was shocked until I started talking about my experience at the psych ward and with my broken vagina in comedy clubs, okay? The amount of men that slide in my DMs, not to say, oh, you're so beautiful, can I take you out? But to say, oh my gosh, my wife experienced the same thing. That's why our relationship didn't work out. Or, oh my gosh, my wife is a nurse, but she had the same outcome that you did, Angelina. I've never heard anybody talk about this kind of stuff. Right. And men will come up and say, well, wow, well, what was it really like? Like, my wife is pregnant, or my sister is pregnant, or yes, my daughter had the same experience. I met with Rick Scott, Senator Rick Scott, a few weeks ago in Washington, D.C., while discussing some legislative work that I'm doing with March of Dimes. And Rick Scott even mentioned to me, I'm gonna throw him under the bus, but even Rick Scott mentioned to me that his daughter is going through IVF. And she's experiencing some adverse mental health, not issues, but she's anxious about getting right. Mm-hmm. And that's normal. That's not throwing anybody under the bus. But it just goes to show that men need to be included in these conversations. Yeah. Right? They need to be educated. They need to feel just as empowered as we do as birthing people. They need to feel empowered to tell us that we're off without judgment. They need to feel empowered to take action, and they need to feel empowered to educate themselves and to even maybe educate us, right? It's a team effort. It's a team support. So it's important that we don't isolate the men. I love them.
Yeah. Right? Don't forget they should be empowered to get up so you can sleep too.
Yeah.
Child care. That's right.
Yeah.
That part.
Yeah. And I do want to add, just piggybacking on that while it is mostly the woman or the birthing partner, there is an incidence of postpartum depression and anxiety that can happen in fathers and in the non-birthing partner. So dads can have intrusive thoughts about hurting the baby. Dads can have postpartum depression. Their role is totally changed in the family and in the relationship. So it is something that is there's starting to be more research about it. There are more therapists who are focusing on it. There are support groups for dads because, a risk factor for dads developing postpartum depression is a wife who has postpartum depression. So so all of that is something that we're talking about maternal mental health, but family health is maternal health.
Definitely.
Another risk factor we didn't talk about is a baby in the NICU.
Yes.
That's a big one.
I'm so glad you mentioned that. And I think one thing that, Lauren and Angelina are bringing to light too, is the fact that for so long, we only ever talked about postpartum depression. But what we're seeing with people being more open and some of the stigma going down and some of the myths being busted is that indeed the reproductive journey begins much, much, much earlier. The very first time you and your partner start talking about and thinking about having a family. And so, if you have struggles to get pregnant, that's very, very stressful. Mm-hmm. If you have to go into IVF, if you have perinatal loss or losses, that can be incredibly depressing. I mean, you can imagine that would be very, very upsetting.
Right.
So again, I think that, Lauren's app, the mobile health app, the reproductive psychology program, and similar programs are out there to help individuals through their entire reproductive journey, not just during the pregnancy and immediately postpartum. And we do have unique groups for perinatal grief and loss. We do have unique groups that include fathers. We're about to have a NICU support group that's starting. So I'm so glad you mentioned that, Dr. Gregory. And I think it is critically important. Someone mentioned sleep. Sleep has come up a few times. I'd like to talk about that for just a second. Because sleep deprivation is a form of torture. It is used as a form of torture. So when we're pregnant, we're uncomfortable, we can't sleep, we're getting a little glimpse into it, but then you got a baby crying, screaming, waking you up every 2 hours. So this is a group effort with the partner, with perhaps a doula, with perhaps a night nurse, with perhaps a mom or a mother-in-law, whoever it is. We do need a village. I don't know whatever happened to it, but we need it. We need to bring it back. Bring back the village, because we can't get chunks of sleep. It doesn't have to be continuous sleep, but we need to get multiple chunks of sleep. And dads need it too. So again, I'm so glad that the dads and the partners are being brought up.
Yeah. And I see a lot of companies now are doing parental leave. So it's dads and mom. Yeah. So that's also very helpful. We have like 10 minutes left, and I want to make sure we talk about this RISE study. Dr. Afor, can you please help us?
Thank you so much. I so appreciate you bringing that up today. This is a study that, as you mentioned, Dr. Gregory, Dr. Bamboget, and I have had in the works for many years, just knowing that the risk for perinatal mood and anxiety disorder doubles for women of color and Black women specifically, and understanding some of the barriers that get in the way for Black women in particular to get the mental health care that they need. And so we partnered with Lauren Elliott and at Candlelit Care and Maternal Mental Health Now, a local organization. And essentially we're testing the unique modules. So there's a lot in Candlelit Care that's so valuable. There's 9 or 10 modules, there's coaching, there's so much rich information there. But we have pulled, Lauren has pulled for us, these sort of culturally relevant elements, and we are testing them in a pilot randomized controlled trial. So we are recruiting Black pregnant women, Black pregnant individuals, basically any time between 12 and 32 weeks gestation. So if you or someone you know is pregnant, please reach out to us. We'll have a link or something.
It's down there. It's scrolling, everyone. So
amazing. Thank you so much.
It's going down. For information about the RISE study, email risestudy@cshs.org.
That's amazing. And so essentially what we're going to ask you or your friend, if they do contact us and agree to participate, we will ask for that individual to obviously interface with an app. It may be our control app, or it may be the one that Candlelit Care has informed, but you will interface with that app for about an hour. You'll also fill out some screening surveys. We don't just ask about depression and anxiety. We want the full picture. We want to know about social support. What's going on with your husband? What's going on with your family? We want to know about nutrition, exercise. We want to know about experiences of medical discrimination. So we're going to ask you, it's about 30, 45 minutes. We do ask a lot of questions, so we appreciate you very much. And we do compensate. We remunerate all of our participants for their time. So it's $20 when you fill out a survey, $20 when you interface with the app, $20 if you choose. As Dr. Gregory mentioned, we do understand inflammation may play a role in the mechanism here. So we do want to get a better understanding of what's going on mechanistically. And so we do ask for a small amount of blood, but that's optional. You don't have to do that part if you're not interested in doing that part, but we do compensate you for that as well. Then we follow you through your pregnancy. We don't bother you. You deliver, you do your thing. You could be anywhere in the United States of America. So I think it's important.
That's what I asked.
Right? You could be delivering anywhere. A little while after you deliver, we will reach out. We'll have a short survey just asking you, checking in, how did things go? was your baby in the NICU? What was that like for you? So on and so forth. And then we'll do another survey, another 30, 45-minute survey, 3 months postpartum to kind of see, well, what did you think about this app and how did things go? And emotionally, how are you doing at this time? So it's a really exciting NIH-funded pilot RCT. We are recruiting throughout 2024 and maybe into 2025. So maybe you're trying to get pregnant. So even if you're not currently pregnant, please keep us in mind and please do reach out. I would love for Dr. Gregory or Bambajay or Lauren. Angelina knows about it because I talk her ear off about it too. So anybody, please add.
I actually met some moms in Atlanta a couple days ago that I knew Cindy was. Who were pregnant.
Oh,
yeah.
Awesome. Anyone else?
I don't know if it might be helpful if Lauren, you wanted to share just briefly what we mean by culturally relevant modules. I would think that might be a question.
Yes. Yeah. No, what we specifically mean is we're talking about topics that don't often come up, let's say like in a childbirth education class. So beyond breastfeeding sort of practices, talking about the nuances of, hey, yes, we know that there is a movement toward breastfeeding and breast is best, but giving space for women to kind of navigate, birthing people to navigate whether or not that's for them, if they do have to supplement, that's okay, those sorts of things. Topics around ancestry, the fact that they can have midwives and doulas, what their options are. So we're getting very much in the nuance. Another topic that's extremely relevant and culturally relevant is intergenerational sort of trauma. What sort of traumas are we bringing from our moms into our motherhood styles? Those topics being very relevant to specifically how we can help with outcomes.
Somebody's crying. But I want Angelina, you wanted to share something with us because we are going to run out of time in a minute, and I want to make.
Thank you so much, Dr. Renee. Yes, I did want to share that Spicy Moms is an organization that I founded to stand in the gaps of care. We offer mom-to-mom support globally to women in over 3 continents. We worked on legislation aside Dr. Einab Acourt to pass legislation for mandatory screenings in California. The governor signed sweeping legislation. So now I'm working with March of Dimes and a host of other organizations, but many legislators on Capitol Hill to duplicate those same pieces of legislation across the country so that women in Kentucky, women in Mississippi, women in Oregon have the same level of care and they can get screened. It saddens me that screening is not mandatory. Like, why we're not being educated, we're not being screened, and and the stigma's in place, right? Mm-hmm. So the screening is the floor. That's the floor of where we're trying to reach for, right? At this time. But also, Spicy Moms, we are launching in Washington, D.C. on May 25th with a 3-year residency at the Kennedy Center. So maternal health will have a home for the next 3 years. We speak a lot about stigma. We talk a lot about moms not having the space to understand their own feelings and to connect with each other. And we're hoping through this partnership with the Kennedy Center that Spicy Moms can have and create that space where moms can come, laugh, learn, and and fellowship with each other. And then lastly, Spicy Moms is launching in France this summer during the Olympics in Paris, and then finally in Ghana, West Africa in November. So we look forward to serving moms all across the globe and igniting postpartum education, mom-to-mom support, and standing in the gaps where the systems haven't yet caught up. Right, Lauren? It's important that we do Correct. What we can to support, not to alter or change any systems, right? But we're here to support and stand in the gaps so that moms at least know what they're experiencing, and that families, all families, for intergenerational families, your grandma can say, "Oh, wow, you just taught me something. I too had postpartum anxiety, but didn't have to do that and say that." So please follow us at Spicy Moms with an E. Spicy.
Amazing, Angelina.
Around the globe.
That's awesome. Thank you so much, Angelina, for all your work. I mean, and you're a mom and a wife on top of all that. Okay. But thank you so much to our partners from Cedars-Sinai, Candlelit Care, and of course, Angelia Spicer for this informative discussion about wellness and Black maternal mental health. Thank you to our outstanding guests and physician mentors for joining us tonight. Angelina Spicer, Lauren Elliott, Dr. Kimberly Gregory, Dr. Enav Acourt, and Dr. Simi Bambouje. And if you are in Los Angeles and want more maternal mental health resources and Cedars-Sinai's obstetrics and gynecology reproductive psychology program, we will post the link in the chat. Producer, did you put the link in the chat? I hope so. But it's cedarsinai.org/program/obstetrics gynecology /specialty/reproductive-psychology.html. Okay. So hopefully we got that in the chat. And for our viewers, Cedars-Sinai has partnered with a third-party vendor, Find Help, to offer local community resources online. So the site offers everything from free or reduced cost resources to access in your community, like mental health care, sexual and reproductive health care, health education, child care, food and transit assistance, and more. So visit the site, Find Help, and type in your zip code to find out which resources might work best for you. To find it, you can scan the QR code on the screen now. And we will also insert the link into the chat. So it'll go on everything. You'll see that. And we hope this conversation offered resources for well-being and affirmations to all the perinatal women and Black women experiencing PMADs and motherhood. Thanks so much to Cedars-Sinai for all of us here at blackdoctor.org. Good night. Thank you, ladies. You guys were amazing.
I didn't get that.
And then Siri is trying to talk.
Good night. Thank you. That was great.
Good night.
Thanks, everyone.
Thank you.